Palit, an eminent neuropharmacologist and academic leader, previously served as the head of Division of Pharmacology at CSIR. His award-winning research focuses on neuropharmacology, stress research, and R&D in drug discovery and development. We welcome you, sir. I would request, sir, to introduce our speaker, Dr. Bandopadhyay, to take the forward session here.
हेलो
ये नेक्स्ट है
ये बैक है
ये
बैक
बैक था ये नेक्स्ट
ये नेक्स्ट
और ये ये वाला
गुड मॉर्निंग ऑल ऑफ यू
ये वाला ना
इट इज माय ग्रेट प्रिविलेज टू इंट्रोड्यूस प्रोफेसर एस के बंदोपाध्याय आई नो हिम फॉर a very long time. He's a very dedicated and hard-working pharmacologist. Hello. Yes. Hello. 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 Okay. So again, I just want to introduce Professor S K Bandopadhyay. He is very known to me, and he was the president of Indian Pharmacology Society. Besides that, he was the Director General of Medical Health and Education in West Bengal, and he has published numerous papers. And what I find is that he is very dedicated in his work. Whenever there was a problem with West Bengal, I have seen that he has come out and tried to solve the numerous problems during this period. And he is a fellow of esteemed medical society. He has delivered numerous invited lectures in India. At present, he is the visiting professor in China. One thing I want to share with you that we are having this oration, Dr. Govind Acharya. And was my privilege that he was my MD external examiner. In Lucknow, when I was appearing for the MD examination, Dr. Govinda Acharya came as my external examiner. What a nice person he was. He belonged to Patna, and his wife was also a gynecologist and very soft-spoken, but full of knowledge. And besides, Dr. Govinda Acharya was one of the persons who has established, who have introduced Indian pharmacology. With few words, I will now request Dr. Bandopadhyay to speak on this oration lecture.
Well, now it's afternoon perhaps. Good afternoon everybody. No, it's still morning. Good morning everybody. Actually, really it's my proud privilege to deliver a oration on a person. In fact, he is a father in one way, because in his hand the IPS was established in Patna, and during my student days in BHU, I still remember once I had the opportunity to receive him during MD examination at Mughal Sarai station. I was thinking this morning that today I will be delivering oration on his name. Anyhow, thank the organizers and executive committee members for allowing me. So actually I have chosen a topic that Winston Churchill once said, the further backward you can look, the further forward you are likely to see. Why I am telling this quote? The reason is that we shall have to look back if we are to know the present status of medical education, we shall have to know the past. And if we know the status to present status, we shall have to look forward for the future, because it is absolutely rotating, dynamic and dynamic. Actually, the history of medical education goes back to the era Actually, there was a system that was called the Gurukul system during 900 to 1100 centuries, when there were the students were being stationed in the Gurukul, and the teachings were being done to the students, and you know, heard the name of the Sustita Samhita and all these about that when they used to deliver classes, the basic thing was mainly on didactic lectures. And then actually first in India, medical education came through Egyptians, and through then the Britishers brought the medical education in our country in 16th century. If you look, that medical college was established in the year 1835, and it is during the British period they developed the idea, they had the idea that we shall have to educate the British youngs as well as the native young people, and through medical colleges. That was the establishment. And then in the same year, Madras Medical College was established in the same year, and the Grand Medical College Bombay, it was established in 1845. So in these places, the medical colleges were established in these places. And then, of course, the Sanskrit College was also established. And in Indian Medical Council Act was the first Medical Council Act was in 1933. And on the basis of that act in 1934, the first Medical Council of India was established. And then is medical education, the case started, this medical education was after independence. The Medical Council Act was established finally in 1956. Then the developmental era started actually first through Srivastava Committee, when the launching of rural health service started. In fact, we were interned in those days that we had to move to the primary health centers for the training and other things during that period. Reorientation of medical education, the Rome program was very popular in those days, and Government of India was thinking in many directions to do many more things. Then the Bajaj Committee, the establishment of Educational Commission for Health Sciences was established. Medical curriculum before 2019 were basically on didactic lectures, that is basically on teachers who were active, and the recipient students were passive, subject centered, time based, focused on knowledge only, no possibility of any feedback. And I do not know how many medical students are here. Let me tell you one very funny story. When I had the opportunity once to go to China to teach students, and normally I used to teach students to Chinese and Indian people. And one day I found some Chinese students were sitting in my class, and I asked them, what you are doing, why you are sitting? Oh no, I heard about your name and all that, whatever it is. After the class, the students, the Chinese students came to me, and they were so surprised. They asked, that's how dear the students were, sir, asking you the question. And why? Then they told me, we are not supposed to ask any question to our teacher. Whatever the teacher will say, that will be the finalized. That will be the final thing. So that was the status, not only in China, but also in our country. The same thing. The active was teacher, passive were students. And Now, there are certain advantages and disadvantages. So, the time is short, so I will have to move fast. Otherwise, I could elaborate in detail. Advantage is structured environment for learning, focus on our foundation skills. Authority of teachers, definitely a positive point. Availability of resources, because why the resources are more? Because we get the information from the texts. So, naturally, the resources are more. Has a proven track record, assessment is easy, covers more content because we are providing the content from the text as a whole. And disadvantage, the first and foremost, practically no engagement of the students. So, automatically a real world connection less, lack of personalization, contrast between memorization and understanding, not flexible, overemphasis grades, limited emphasis on life skills. And so, across the ages, it formed like this informal apprentice, standardized curriculum, subjective integration. Then the most important thing which came in was bedside teaching. I will be trying to telling you as quickly as possible. This is now the order of the day, outcome-based learning, interdisciplinary team-based teaching, utilization of bedside teaching and the stimulation. This gentleman first discovered Abraham Flexner. Then this man, Osler, William Osler, he made the concept of bedside teaching, the medical residency and clinical clerkship. And outcome-based learning was demonstrated by Spady. So, you see today's teaching is based on, when we enter, that's integration. Integer is a Latin word, that means the coordination. Integration is two types of integration are there. One is horizontal integration, another is vertical integration. Those I do not find much. Medical teacher is here anyhow. So, subjective integration in medical education, inverted triangle. Nowadays, when we were students, we used to go to the clinics from second prof or second after the first semester or second semester. So, but today, from day one, they are sensitized, students are sensitized. You see 20% are in the first phases, 20% clinical, pre-para 60% and pre-clinical 80% in the phase 1 and phase 2. And then as it is advances, it becomes inverted triangle, 20%, 40% and 80%, just reverse. So, from basic science to clinical science. This hardened spiral integration was there, by which these are all being demonstrated. Hardened ladder integration were there, isolation, because isolation means single subject. Then awareness of the teacher, that is very important. Harmonization amongst the teachers is more important. Nesting, incorporation, alignment amongst the teachers, sharing, correct correlation, complementary to each other, the pre-para and clinical, pre-clinical, paraclinical and clinical. This interdisciplinary, and ultimately the subject identity gets lost when it becomes transdisciplinary. The basic difference between integrated versus traditional teaching. Integrated teaching, unifying topic, holistic learning, emphasizes on understanding of current problem and concepts, more clarification of concepts, less confusing, learning basic sciences. And in traditional teaching, the high degree of compartmentalization of curriculum, fragmented learning, that is the problem of this thing, emphasizes on examination and result. So, when we were students also, our main motto used to be how to pass. No question of how we will be a good doctor. There was no such question was there. The main motto were there how to pass the exam. So examination oriented teaching would be there. Lots of confusion in students. So naturally, students are thoroughly confused, different information on same topics, and while learning clinical and other things. Outcome-based learnings I have already discussed because the time is going short, that is becoming a big problem, so I will have to hurry. Now after 2016, National Medical Council came, and then this NMC Act was enacted. NMC Act was enacted, and it was then totally the competency-based undergraduate curriculum for Indian medical graduate started. What were their basis things? Foundation course. Today, in undergraduate curriculum, foundation course is a must. Early clinical exposure, I have told you from day one, students are exposed clinically. Electives, alignment and integration, I have already told you. Learner-doctor method of clinical training. Role of an Indian medical graduate. So, if we see that the role of a medical graduate should be professional, researcher, a communicator, critical thinker, leader, lifelong, clinician, professional, ethical, responsible and accountable, patient, families, colleagues, community, analyze patient information, problem solving, informed decision, and leading the health team, that is also leader. Leadership is a very important part of the Indian medical graduate at day 2. So this is also teacher centric. Now self-awareness, this is also very important, interdisciplinary, collaborative, problem-based learning, small group learning, project-based learning. These are the order of the day. And now different technologies are now has enacted in this today's modern system of medical education teaching. And actually not today, it has started from, if you see, that photography slides were established in 1819, far back. Then film strips were there in 1910. Overhead projector, in fact, I could tell you many stories, but the same problem, time constraint, I cannot go in detail. Anyhow, multimedia approach started in 1980, multimedia approach. Then simulation has become a very, very important role in medical education curriculum today. In 2000, cloud-based role, then artificial intelligence everywhere, everywhere and everywhere. I will tell you in a very short period, and this AR and VR. So, newer methodologies, simulation-based teaching, this is applicable in pre-para as also in clinical. This team-based teaching, so no isolated, team-based, always the teaching system. Flipped classroom, do you know any idea about flipping classroom, flipped classroom? Flipped classroom is that a pre-prepared teachers, lecturer there in the computer, and students before entering the class, they will go through this and they will learn all these things time and again, this flipped classroom. So that what will happen, they will get themselves more oriented. Problem-based learning is now order of the day, and definitely very important has become, particularly after COVID 2019, that this distant education, e-learning, that was I was going to tell you, easy access, self-paced, personalized learning, increased flexibility, reduced expenses, resource reusability, immediate feedback, access to expert knowledge, and global collaboration. So these are the advantages of e-learning, which has become now very popular nowadays. Those who are still in teaching, you all know that how this e-learning has been done, and effect are this one actually accessibility, then lifelong learning, then customization and personalization, then evidence-based practices, then addressing knowledge gaps, then access to expert knowledge, and global collaboration and networking, quality assurance and accreditation. So in healthcare professional, this is the present scenario in classrooms, that what is we go. Forget, but still these chalk dusters, still even today, blackboard. You just remember we started our career with chalk duster and blackboard. And now the order of the day is AI in medical education. The question is whether how much we will depend on AI. That is becoming very important, not only in medical education, but in every aspect of life. How much? Should we depend to that extent that we become dependent on AI? That becomes a very important thing that is coming. Now, blending learning, human and technology, because technology has become so fast, so much on it. If you see the technology, mobility, structure, tracking and control, self-study, reduce cost, global research, global reach. And human was always there, motivation, personalization. What I want to emphasize, that human touch should not be deleted. Always, whatever AI we go, whatever AI we do, we should always remember that the human touch should always be there. Now coming to the future directions. So future direction says AI supported individual learning, AI supported, then student driven learning, virtual and augmented reality, simulation based learning we are all doing in, I believe those who are teaching the simulation not only in pre-para but also in clinical practice. This simulation has become very important part, so that is going on continuously. Stimulation based learning, digital health literacy, humanistic care and ethics, community oriented and longitudinal integration. So these are the future direction, as I was going to tell you that what should be the future direction of the medical education today. Now summarizing, medical education is a pivotal juncture requiring continuous evolution to meet the demands of modern healthcare. Evidence support the benefits of integrated curriculum, hybrid instructional models, diverse assessment strategies, early clinical exposure. This is very, very, very important. Now has become mandatory, early clinical exposure, because ultimately it will become a medical graduate. When it becomes pass out MBBS, it become medical graduate. By embracing evidence-based reforms, medical schools can optimize their curriculum to produce competent, compassionate, and adaptable physicians who are prepared to meet the evolving needs. Medical education is at pivotal So, thank you very much, and the change is the law of life, and those who look only to the past or present are certain to miss the future. So that was told by John F. Kennedy, and I believe that change and change, that is the most important thing. Suddenly hall has become quite scantier because perhaps the star campaigners have left. Anyhow, thank you for your patient hearing. Thank you very much.
Thank you, Dr. Bandopadhyay, for completing all the whole thing in a very short period. Thank you for your presentation. Thank you.
Thank you so much, sir, for such an enlightening talk indeed. I would request our chairperson to felicitate the speaker of the day, Professor Bandopadhyay. I would also request the IPS core committee to please grace the dais and felicitate our chairperson, Professor Babul sir, Shiv Prakash sir, Devan sir. Can we have you here? Thank you so much, sir. So now is the tea break time. We all are going to assemble here after 15 minutes. Please take care of the time. We have to assemble back here after 15 minutes. Thank you.